gentlemen, we will try and get an on-time start for this session this afternoon. My name's Jason Abbott and I'm going to be co-chairing the session this afternoon with George Kondus, who's also the co-chair of this meeting. George hasn't lost weight. He's behind the screen and is hopefully getting set up for his live scan. So we're going to start off with the live scan, and George was telling me a little bit about this lady, and of course this session's all about pelvic pain and endometriosis. And this is a sonovaginogram of a lady who's 49 years old, and she actually has had a previous excision of endometriosis some 6 years ago, and she's represented with some pain. So a live scan is all about looking at possibly recurrent disease. I kind of feel like a bit of a cheat because I know what's there. That's the presentation. So we're going to have a little bit of a look at that. We've also got a little bit of a change to the program as well. Stefano Guerrero is going to present his papers first. He's got to get off to a board meeting, so he'll be presenting, and then we'll move through the rest of the program as it sees listed up there. So hopefully we're almost ready out the back. George, can you hear me?
Yes. Can you hear me?
Fantastic. We can hear you.
Very good. Good
Outstanding.
afternoon, Jason. Afternoon, everybody. So I'll get started. Yes, and you guys can see what we can see. Excellent. So Jason's introduced this lady. As we talked about the course yesterday, it's a systematic approach to the pelvis, and so what obviously I'm going to do routinely is assess uterus and ovaries as you would do at a regular ultrasound scan. We'll get our pointer up, and you can see this young lady's got a marina inserted. Yeah, that's great. So that's just sitting obviously correctly in the fundus of the uterus. She's also got, looks like probably a small anterior intramural fibroid. The endometrium looks pretty unremarkable itself, so we're reasonably happy with that. As I move across, obviously I'd measure that in the three planes. As I move across towards the right ovary, which is coming out laterally here, we can see that. I'll just increase the depth. Can we get some colour on as well? Yeah, that's great. Yeah, just increase that box. That's good. And you can see that there's a unilocular cystic lesion. I'll just grab that arrow as well. That's fantastic. So just in this vicinity here, multifollicular ovary, and if we take our colour off, so I think there's a tiny unilocular cystic lesion with ground glass material here, and this is the right ovary, so I think she's got an endometrioma in the right ovary. We'll just drop the depth, and then whilst I'm there at the same time, I'm just going to gently, because she's a little bit sore, as I move the probe, you get the impression that up against the pelvic sidewall, just in this vicinity here, I think there's a little bit of movement laterally, but if we look in this vicinity here to the medial aspect, as I push the probe, there seems to be some fixation between the ovary and a structure here that we'll look at later, and also the uterus medially. So I think this ovary is fixed medially. We come back to the midline again, we drop our depth, and I'm going to swing across to the left side. And I don't have to swing too far before we can see an endometrioma in the left ovary, and it seems to be in the pouch of Douglas. And you can see again quite clearly as I just gently move that probe, there's very little movement between the ovary and the uterus itself. So this is probably in the pouch of Douglas. And also as you move the probe, you just get the impression that the whole pelvis is probably fairly fixed. And I'm sure it's something that Jason would, I'm sure, have to map out some significant amount of time in relation to clearing the disease. So we're happy in relation to the uterus, the ovaries. I think there's bilateral endometriomas. I think the ovaries are fixed. Before moving forward, the other thing that I'll do is drop the depth. Then I come back to the uterus, and now I just want to elicit the sliding sign. So we talked about this yesterday. So with an anteverted uterus, I keep my right hand still. The probe is in the anterior fornix. And with my left hand, I gently push my left hand on top of the suprapubic region and push down. And you can see quite clearly there, we'll bring our arrow back on. And you can see at the anterior fundus, there's definite movement there of the bowel contents up against the uterus itself. If we focus posteriorly, down in this vicinity here, as I press gently there, you can see there's movement here, but you get the impression that from the level of the posterior uterine fundus here, there's no movement. I'm pushing the probe now, there's very little movement. So I think at the posterior fundus of the uterus, I think the sliding sign is negative. And as we move now down towards the retrocervical area, which is this vicinity here. I'm now lifting my hand quite high and the probe's pointing down towards her sacrum. And as I just gently, now my left hand's by my side, and as I press on the probe, there's very little movement there at all. So again, I think that the bowel is fixed to the retrocervical area, is also fixed to the endometrioma, which is just here. So we've got a fixed obliterated pouch of Douglas. And I think one of the things that we're starting to do is actually classify the degree of obliteration. So I think that this is probably a complete obliteration from the level of the retrocervix right up to the posterior uterine fundus. So there's no doubt that she's got significant disease. So we've done what I think a fairly straightforward scan to start with. Now, most people would leave it at that point and say she's got bilateral endometriomas, and that would be the report that's generated. But it's about trying to get additional information in relation to the ultrasound scan so that when we generate reports for people like Jason, it's going to help him in planning his surgery, planning the instrumentation, planning the timing of theatre allocation, and also having the right team available. Because as we said yesterday, there's nothing worse for someone like a generalist to be faced with a potential frozen pelvis, because then obviously that woman's had an unnecessary laparoscopy. And similarly, I think the benefit for the advanced endoscopic surgeon using the technology that I'm going to go into is that it's possible to plan the surgery rather than being faced at the time of surgery with a bowel nodule for the first time in a woman who's not bowel prepped. And we saw the videos yesterday of Danny showing a woman who hadn't been bowel prepped, and you could see how messy it became when they made a hole in the anterior rectum when they were trying to actually use what I call the bum gun. So not having bowel prep and coming across a nodule that you didn't know about is probably the worst time to get the colorectal for an intraoperative consultation. So by having as much information preoperatively, it enables the team to plan the right surgery. So coming back, what I'm going to do now is I'm going to take the probe out and I'm going to pop some gel into the posterior vaginal fornix. I'm just going to get some gloves, so bear with me. So that's good. And I've got another glove. I use a 20 ml syringe just with some ultrasound gel, and there's obviously no needles. I explain to the patient that I'm going to just pop that syringe just up against the introitus. I usually just do a gentle examination first, just to make sure that, we're going to make sure it's going to go into the introitus and not into the urethra. And basically there's no needles, and it gently goes in. Sometimes there's some small little air bubbles. Pop your feet up for me. That's okay. And they just explain to the patient that sometimes you might hear some noises just as the syringe empties into the actual vagina. So I've literally just probably got less than a centimetre of the actual syringe inside vaginally. There's nothing to feel vaginally. And then when I come now and rescan, I'm now going to bring this probe, so my elbow's resting on the bed, so the probe's now going into the posterior vaginal fornix. I'm going to hope that we've got a reasonable view, which we have. Yeah, we do. Okay, great. So you can see straight away that we've got a really nice view here. So arrows come up. So we've got bladder to the left of screen. We're going to evaluate the anterior compartment first. We've got the vagina now distended with gel. And there's enough urine in the bladder, I think, to actually have a look at the bladder itself. This young lady's got no bladder symptoms, and I know from previously scanning her that her bladder's fine. You can see some jet there from the ureter. Come to the vaginovesical septum, which is almost always normal. So this is this vicinity here. And then coming to the anterior vaginal fornix, which is almost always normal as well, just in this area here. So we'll just increase the depth on that. Bring the probe in a little bit more. So now I've got it angled almost straight down towards the floor. And so we've got vagina here distended with gel. This is the rectovaginal septum. And as I said to those that came to the course yesterday, for a very long time I was looking in the rectovaginal septum, and then we were operating on these ladies and they had a clear septum, but they had disease. And I couldn't work out as to why I was getting it wrong, and I was looking too caudally. So most women's disease starts at the level of the retrocervix and either infiltrates caudally or migrates cephalically. So this is the vicinity that we need to be looking at. You can see quite clearly as well, we've got the outline of the cervix. Here's the posterior vaginal fornix in the mid-sagittal view. And I come to a transverse view and I lift the probe again, and we're looking nicely at the fornices of the vagina. As I move laterally, we can see this is the rectovaginal septum, which I said is almost always normal. So I think that the gel enables you to get some sort of standoff, so you can see quite clearly here you've got a beautiful mucosa vaginally, that's normal. and you can also delineate the rectovaginal septum. So for vaginal disease, you'd expect to see a thickening in the vagina in this vicinity here, but I think her vaginal wall is normal, so I don't think there's any vaginal nodule. Also in the same position, I gently move laterally from one side to the other. You can't normally see uterosacral ligaments, but if there's obviously a nodule present, then you can pick that up. When you look at our data that Shannon Reed will present today, our performance for uterosacrals is probably the worst when it comes to us picking up DIE. But we talked about this yesterday, and I think Jason and I are in agreement that if the pouch is clear and there's no anterior rectal or rectosigmoid nodule, if you miss a uterosacral nodule, I don't think it's necessarily the end of the world. So it's still relatively probably level 2-3 surgery. So now I'm going to bring this probe right back to the anal verge, which is just in this vicinity here. I'm a little bit disorientated. The probe is this way. Yeah, there we go. Okay, that's better. Good. So bring it back to the anal verge. Okay, so we can see the anterior muscularis. The bright white line is the submucosal layer. Here is the contents of the bowel, and here is the posterior submucosal, and then that shadow there represents the posterior longitudinal muscularis. So I'm going to follow, and you can see here quite clearly I'll increase the depth again. In the anterior longitudinal muscularis, you can see that there's the line that divides the external longitudinal and the internal circular muscles of the muscularis propria. So you get a really beautiful view of that. If there's going to be endometriosis, it obviously sits in this area first, and then from the external area, it then invades inwards. So I'm going to follow this muscle cephalically. So we've still got it here, and you can see nicely there's the muscularis divided into longitudinal and also the circular muscles. Still moving cephalically. So you've still got normal muscle here, still got normal muscle here, still got normal muscle here. And now for all and sundry to see, we just drop our depth a little bit. And you can see coming around here, we've got this very impressive anterior rectal nodule. Now, it's probably slightly smaller than when I scanned this lady 3 months ago. She's got a marina. Whether or not that's made a massive difference or whether it's just me changing my ability to measure some 3 months apart, but it does seem objectively somewhat smaller. So if we measure that, we'll freeze that. And you can see that this nodule is in the mid-sagittal plane around about 50 millimeters. And in the AP is 12 millimeters, so we'll archive that and then unfreeze that for me, and then we'll come to the transverse view. And here it is in the transverse view, so we freeze that. And you can see in this view here, we can measure that as well, and we'll keep that as obviously on file. Yeah, that's good, thank you so much. And then, yep, that's just to there, freeze that, good, and archive that. So you can see in this plane here, if I have an arrow, you can see really clearly, I think in this case, the muscularis propria has basically been replaced by this endometriotic nodule. I think we've got an absent Indian headdress sign, so I think that the submucosal layer is intact. And so, but the most important thing also is we then come back and unfreeze this. What we want to do is go above that because we want to make sure there's not a skip lesion, okay? So here is our nodule here. We'll have our arrow back. Good. So now we've got normal muscularis again as we head cephalically. Normal muscularis. You can see contents of the bowel. And we talked about this yesterday. This woman hasn't had bowel prep. I don't think that you need to have bowel prep. You can see the views that we're getting today. I think they're absolutely beautiful. So you've got a fantastic anterior longitudinal muscle that's divided into the longitudinal and circular layers. Contents of the bowel. Here's the submucosal layer. Posteriorly, here's the submucosal layer. And here's the posterior longitudinal muscularis. Again, divided into the longitudinal and the circular muscles. So I think fantastic views. As I move more and more cephalically, do I think that there's a skip lesion? I don't think so. So I'm pretty much at the extent of where I can see. So I think we've got an isolated anterior, there we go, anterior rectal nodule. Now the other question is, the question that Jason wants to know, and I'm sure he can agree with me, is whether or not the pouch is obliterated. Because if the pouch is not obliterated, it's a much easier procedure, isn't it, Jason?
Yeah, absolutely, George.
Yeah. And so reducing our depth. Yeah, that's great, thanks. So here is our nodule just here. So you can see posterior vaginal wall, posterior vaginal fornix. nodule starting almost at the upper aspect of the posterior vagina. Cervix is here, coming into lower body of uterus. So if I gently move the probe, I'm sure you can all appreciate there is no movement between this nodule and the uterus. There's no movement between this nodule and the cervix, and there's no movement between this nodule and the vagina. So I think that we can say that apart from the fact there's this anterior endometriotic nodule of the anterior rectal endometriotic nodule, we can also see that this is the reason that she's got an obliterated pouch of Douglas. So bilateral endometriomas that I think are fixed to the uterus. She's got a large anterior endometriotic nodule with an obliterated pouch of Douglas. So the report that we would generate would obviously comment on all these things, and I think that that would potentially add some value in the preoperative management of this woman when it comes to planning her surgery. So I don't know if there's anything that anyone else front of house wants me to elicit, Jason, or are we happy to move on?
Is everyone happy? I mean, they were beautiful views. Even a laparoscopic surgeon can see that, so you guys should be experts.
And
anyone got anything else that they really wanted to see? I mean, it's all about, obviously, the posterior compartment here. And as George says, in terms of planning, 5 centimetre rectal wall nodule with fixation not only to the retrocervix but up towards the uterus means that we're going to have to do pretty much an all-day procedure. A segmental rectal resection is most likely given a 5 centimetre lesion. And you could see that cicatrisation as well of the bowel, how it folds in on itself. And that's one of the things that we see surgically, that the lesion will actually pull the bowel walls together, and you'll see the disease as it sort of forms a C from a linear lesion as it pulls everything around, and those deeper layers will curve around. Has anyone got any questions on that live scan? Very nice views, very nice presentation, and thank you to Mrs. X, we will call.
Yeah,
yeah,
thank
sorry,
you, Mrs. X,
here.
absolutely. Thanks so much. I'll come and join you.
Sorry, can you just say that again? George, the question
we'll
is,
is
there any colour, blood flow that you look for on the bowel?
Yeah, I mean, you can put some colour on it. It'll be avascular, but it's always a good thing to do, because sometimes if we increase the box on that for me, so increase my res box, yeah, that's great. That's good, more, that's good. And then lock that for me. Good, and then just increase your gain for me. So up that as much as possible. And then drop the gain away, I'll do that for you. So yeah, the reason that I would use that on occasions is not because I'm worried about the vascularity of the nodule, is you just want to make sure it's not a vessel, Jason. So these hypoechoic lesions are classically
We'd cut it out anyway, George. We'd have a go.
Yeah, if it's a vessel, yeah, you can take that one out, absolutely. So yeah, absence of vascularity to the question on the floor.
I think it's an important point to make sure it's not something, but endometriosis is very, very rarely vascular. It has very poor blood supply in actual fact. So you don't see much flow through it, but you're right, if it lit up like a Christmas tree, then you might be concerned that it's in fact not endometriosis, that you were dealing with something else. And it's almost always going to be in the anterior compartment of the bowel wall rather than retrorectal, although George and I last year did have a retrorectal lesion that actually curved all the way around the bowel and went to the presacral area, which was fairly nasty. Good. George, thank you very much.
Great, thanks so much.
That was lovely, and thank you to our patient as well. That's fantastic. So we're going to move on to our